On behalf of myself and the entire Maxius team, I'd like to thank you for taking time out of your day to spend with us here for the next 45 minutes or so. You may wonder why I said Maxius and BioXclude. Well, in case you weren't aware, BioXclude was acquired by Maxius back in September, so we're now part of a much larger regenerative portfolio. And with that, I know you didn't come to listen to me talk. I'm excited to turn it over to Dr. Vinay Bhide, excellent clinician and just an all-around great guy. So it's all yours.
Great. Good morning, everybody. Thank you so much, Matt, for the kind words and the warm welcome. I love the biographies that are just like, this is Vinay, he's a periodontist. I don't like standing up here while all the accomplishments are read out. So yes, I'm a periodontist based in the greater Toronto area. It is an honor to be here in front of my colleagues talking particularly about something I'm very passionate about. I've been on this personal, professional journey when it comes to regenerating bone for deficient ridges as well as for peri-implant defects, probably for over the last decade or so in particular. So the upper left side has my QR code. If you go ahead and scan that, that'll link you to my Instagram, social media. Take a look at it. If you like it, give me a follow. If not, that's okay. But I want you guys to post, take pictures. Just let's make this event nice and social. Let's blow all the other corporate forums out of this room, okay? Or out of this convention center. I can't believe it's been 6 years since I was last in Seattle. We were here for a family vacation for an Alaskan cruise. And there's something about Seattle that makes me feel like home. It's like really in alignment with my vibe. So many beautiful places to see, but I particularly will recommend you guys go to Mopop, especially if you like Pearl Jam and Nirvana and the Foo Fighters and all these nice musical acts. So nice to be back in Seattle after almost 6 years. Hope to come back again sooner than that. And as Matt mentioned, as I mentioned, I'm from Toronto. Born and brought up in Toronto, the center of the universe. But when I'm not enjoying my city, I'm practicing in this small town, which is about 20 miles, 30 kilometers north of the greater Toronto area, this town called Aurora, which is like the small big town nestled amongst a lot of these, even smaller townships and villages. So our catchment radius of referral is about 30 miles from either direction. So it's just close enough to the big bad city of Toronto, but just far enough away that we don't have to deal with the riffraff that comes along with the big bad city of Toronto. We have a group periodontal practice, very busy, and this is our work family. And as most of you know, we spend more time with our work family than our real families. And these are an outstanding collection of individuals that work very well together, work very well with us, and allow us to do the stuff that we love to do to the best ability possible. And I'm blessed to work with 4 other periodontists in this group practice. And the benefit of working in a group practice is that you can get a lot of perspectives other than your own. And it's really nice and humbling when you're with a patient, you're not sure how to take a case and what direction. You call your colleague into the room, get a second set of eyes on it, and the patient really appreciates that interplay and dialogue between the clinicians. These 2 guys here were my classmates in dental school, hospital residency, and my perio residency as well. So we were together for 8 years. We had full heads of hair in 1997. And over the years, not so much. But we love each other, we work together, and it's a blessing to work alongside these extraordinary human beings. So just some disclosure statements here. I am a consultant, KOL for Maxius. And, I've been using BioXclude, which we'll be talking about exclusively today. I've been using BioXclude. I first started using it, let's say, in about 2009, 2010, when I first heard about it at an AAP meeting. It was a pretty novel concept for me at the time. The problem was that it was cost prohibitive. Being Canadian, we get a bit jimmied on the exchange rate, so I didn't use it for a few years. But over the last 8-9 years in particular, I've used it very frequently in my office. It's been a game changer, and I've really made an intentional attempt to document my cases to the best that I can. I wouldn't be standing up here if I didn't have good experiences with the material, and I have full creative control over this presentation. All the photographs, all the cases that I'm showing today are mine, good, bad, and ugly. I'm not going to show you the most perfect cases in the world, but every single case I show you, there will be some learning component with that case. So today we're going to talk about, we'll review for all those in the room. I don't know how many of you are novice clinicians, how many are seasoned veterans, but it seems to me from the look of it that we have a wide gamut of people here. So we'll review the principles of GBR, guided bone regeneration. We'll also talk about the unique features of BioXclude. What makes this material, biomaterial, biologic, if you will, different from the others in its peer group? And we'll talk in detail about the advantages of this membrane, BioXclude, both in the context of horizontal GBR procedures as well as in the regeneration of peri-implant bony defects, implants that have been affected by the disease process. And all these principles will come together in the clinical cases that I show you that, again, the good, the bad, the ugly, but one thing that I am proud of is some of the longer-term follow-ups that I've been able to achieve over time. So I want to start off with some important concepts. So we all have heard about success, we've heard about predictability, and we use these terms interchangeably when in fact they're very different. And then reproducibility is also another concept that I like to talk about. So let me just step sideways for a second in my field of perio, where anyone that knows me, anyone that follows me knows that I'm a lover of the free gingival graft, okay? So success is when I'm able to achieve a particular result that's favorable. So in case of this recession in the anterior mandible, I do a free gingival graft and I'm able to get complete root coverage. That is a successful result. Now, what makes that predictable is if I'm able to get this particular result a high percentage of the time, okay? And with free gingival grafts in the anterior mandible, I'm able to do exactly that, okay? Get this type of result with close to complete root coverage a high percentage of the time. Now, the third thing is reproducibility. How many of us have gone to courses and lectures where we feel at the end of it that we can do what the lecturer was telling us, only to find out later that we don't get the same result, right? A lot of us have been to those type of courses. So reproducibility, I think, is very important. Everything I show you today is totally reproducible. This is not done by magic hands. I'm not showing you miraculous cases here. You can go to your practices tomorrow with reasonable surgical acumen and hope to experience the same results that I'm going to show you today. So a couple of questions for you, and for those of you who are musically inclined, you'll get this reference. When it comes to bone grafting, I don't want to show of hands here, and be honest, this is a judgment-free zone. When you re-enter a site, are you completely satisfied? Are you conditionally satisfied? Yeah. Are you typically disappointed at re-entry? And are you nervous before you re-enter? Yeah, we're all nervous, right? The last thing we want is to open up a site and we've done a perfect surgery, but then we see that superficial layer of bone which is a little bit soft, and as soon as you start drilling your osteotomy, that buccal plate kind of wavers in the breeze a little bit. You can get your implant in, but you're not sleeping well at night for about 4 months until that implant integrates, okay? So again, the parallel with the free gingival graft is that I want to be able to re-enter a site like I see my free gingival grafts and know that 6 months later, when I re-enter, that more times than not, I'm going to be satisfied with the quality and quantity of regenerated bone. So in order for us to even have any chance of success at regeneration, we need to follow the regenerative triad. Okay, we need signaling molecules, what we attribute to osteoinductivity. We need scaffolding, osteoconductivity, and we need appropriate cells, osteogenesis. And we need these three things working in concert over time to affect tissue and bone regeneration. And you know that saying, all roads lead to Rome. Fortunately or unfortunately, many roads lead to bone. And this is what sometimes can be creating confusion. You can ask 10 clinicians what their cocktail is for bone regeneration, and you'll get 10 different answers. And it's confusing as heck because you start doubting, oh, is what I'm doing proper? Because this guy who is, an amazing clinician is using something completely else, something completely different. So one of the roads that's been very well traveled for bone regeneration is the concept of GBR, guided bone regeneration, which is very well validated both in terms of success, predictability, for over almost 35 years now. And the basic premise is very similar to guided tissue regeneration, GTR, around natural teeth, in that we use a barrier membrane to create a space We then allow for that space to fill in with osteoprogenitor cells that will differentiate into osteoblasts, leading to bone formation. And typically, underneath the membrane, we'll use some type of particulate bone, whether allograft or xenograft combination. Sometimes we'll also throw in a little bit of autogenous bone scrapings into the mix. And just a quick shout out, these illustrations were done by my daughter Mina, who at the time she did them was probably 11 or 12. She's now 17 years old. So she has no idea what the hell she was drawing, but I think she did a pretty good job. As I mentioned, many roads lead to bone, variety of biomaterials available. Okay? You're going to go to another corporate forum that's going to tell you that their bone material is the best, when maybe it might not be. Anyways, you didn't hear that from me. And you can imagine with GBR that the morbidity is likely a lot less than with the conventional grafting procedures that we'd see oral surgeons do, taking block grafts from the ramus, the chin, iliac crest, whatnot. So it's a very elegant way to predictably and successfully regenerate bone, both horizontally and vertically, as we've come to know, especially vertically over the last 10 years or so. We all have familiarized ourselves with Hamle Wang's PASS principle that was published in 2006 that predicates that if you satisfy 4 key criteria, you will probably have regeneration quite predictably more times than not. So the first requirement is primary closure. Not just primary closure, but we need tension-free primary closure, because if we just get primary closure with tension, then a few days later, you'll probably be disappointed because you'll have membrane exposure, graft exposure, which can compromise the quality and quantity of the regenerating bone. Importantly, you also want a good source of blood supply. You want angiogenesis. You want good blood nourishing that healing graft complex. We want to be able to maintain that space. The whole purpose of using the membrane is to be able to maintain that space, to allow for those progenitor cells to come in and differentiate. And then last but not least, we need stability of that entire complex, because if we don't have stability, then we'll have a healing that we don't want. We'll let those gingival connective tissue cells and epithelium cells creep into that wound, and it will definitely interfere with the regeneration of bone, if not the quality as well. Okay? And ultimately, we do this because we want to place an implant in a prosthetically favorable position. So as I mentioned, the barrier membrane is a key component of this whole GBR enterprise. And so some of the considerations that we have to take when we're selecting a barrier membrane is that we want biocompatibility. We want one that is integrated well into the tissues, doesn't cause too much problems, doesn't cause too much inflammation. The purpose of the barrier membrane from back in the day was to exclude certain cell types, namely gingival connective tissues and epithelial cells. But we've now expanded that function or that requirement now more to include as well nutrients, because we know that nutrients from the surrounding area can also come in and nourish that healing bone graft. Of course, we talked about space making and space maintenance. We also want membranes that we know that can be handled well in situ. Okay, there's certain membranes that just don't work as well in my hands. I just don't have the patience to sit there futzing around trying to get them to conform to the site. And then there's other membranes which are almost too flexible that as soon as they get wet, you can't really manipulate them in the site as much as you want to. So you want that nice balance that allows you to manage things clinically. You also want a membrane that can handle complications. And what type of complications do we typically see with membranes? We see exposures, we see dehiscences, we see infections, abscesses, etc. So you want a material that can withstand those complications. And it wouldn't be nice if we had a membrane that was actually contributing to the regenerative process, not just sort of a player in the background, right? We don't want a babysitter. We want someone who actually plays with our kids, okay, and stimulates them intellectually. So we want something that's bioactive as well, ideally. And so with these conventional membranes, you'll see here in these pictures, we've got the collagen membranes, we've got titanium reinforced membranes. They all require external stabilization, either by way of sutures or way of tacks. And oftentimes, the titanium membrane aside, with these collagen membranes, we see this inflammatory response that's associated with their degradation. And this can also be a contributing factor to complications like exposure of the membrane, soft tissue dehiscences, infections, etc., which will, no doubt, compromise the quantity and quality of the regenerated bone. Okay? So, if you're nervous already, going into a site that you've tried to regenerate, then this is not going to help those pangs of anxiety. Systematic review meta-analysis that was done in 2018 out of the group in Michigan, where they looked at the rate of complications with membrane exposure. They found that, let's say, 1 out of 5, almost 20% of sites that were grafted had complications, such as exposure, dehiscences, infection, or abscesses. Another review by the same group where they looked at primary outcome variable of horizontal bone gain, they found that in sites that didn't have membrane exposure, those sites tended to have 76% more bone gain versus sites with membrane exposure. Okay? Now, I don't hang my hat a lot on systematic reviews and meta-analyses in dentistry because, discussion for a different day, there's a lot of methodological issues there. But sometimes you get some reasonable statistics that confirm what you've maybe thought anecdotally in your mind, right? Good to keep in mind. The bottom line here is that exposure is generally not associated with favorable outcomes. So then, enter a material like BioXclude, okay? As Dr. Ratliff pointed out in her presentation, it is derived from placental allografts. It's dehydrated, human, deepithelialized amnion-chorion membrane. I want you to all say that fast in your mind 10 times. It is typically harvested from healthy women, okay, because women that are pregnant typically tend to be somewhat healthy. Not only is it a barrier in the traditional sense, in that it inhibits the epithelial cells and connective tissue cells from coming in, it is also a carrier. Okay, it is also considered a biologic in that sense because it has over 250 different biological molecules, everything ranging from the matrix, the inhibitors of metalloproteinases, to favorable interleukins, to extracellular matrix molecules like fibronectin and laminin, and the list goes on and on and on. And this is what confers the property of bioactivity to this particular membrane. And because it's derived from placental allografts, it is also what we call immunoprivileged, okay? In that it doesn't incite an inflammatory response, because if it did, it would be bad for a fetus, okay? So just like it protects a fetus for 9 months very, very nicely, it's going to do the same thing for our bone. Now, the one thing I'll also mention is in the processing of this material, the epithelium is removed, hence deepithelialized. And what that does is that it exposes the basement membrane, okay, which contains laminin. And laminin is a key extracellular matrix molecule that facilitates cellular migration in a relatively rapid manner. And then last but not least, it is also antimicrobial. Okay? The enemy of most bone grafts and surgical procedures in the mouth is infection. Okay? So if we have a material that has some antimicrobial properties, then of course we're going to look at this favorably. So just to summarize some of the positive biological benefits of an amnion-chorion membrane, it suppresses inflammation, it suppresses matrix metalloproteinase activity, which is important because we don't want collagen degradation in an actively regenerating site. It stimulates angiogenesis, which is a very key component of the past principles. It also recruits progenitor cells to the area. So it's a very active membrane in that sense. And it also stimulates proliferation and migration of cells. And I want to focus on that proliferation migration piece for a second. Okay, I'm going to illustrate this very, very nicely. So this is a case where I took out a hopeless tooth number 30, okay, lower right first molar. And this case was inspired by my good friend, Dr. Dan Cullum, who's actually in attendance today. This is where I first got this idea, where we took the tooth out atraumatically, we grafted the socket with a particulate allograft, covered up the particulate with the BioXclude. And if you look at the pre and the post, you can hardly notice that the BioXclude is even there. It's so thin, okay? It sort of goes against our conventional thinking. It looks very flimsy, but again, it's derived from tissue that's supposed to protect the developing fetus, so it has to have some resilience. And then I close over this area with a continuous diagonal suture using 5-0 monocryl. But I want you to note how much of this membrane has actually been left exposed. And now, at the 12-day post-op, we can see that the vast majority of that area that's left exposed is completely keratinized over. And if we look at that in close-up, you can appreciate that even better. And you can also see that there's very little inflammatory response associated with that. Okay, and I can tell you that when you go in for re-entry, you're going to see very good bone for implant placement. You know, good things come in 2s, maybe 3s, but here's a second case where we took out number 19 atraumatically. This site I grafted with the xenograft, placed the BioXclude membrane over top. Again, same closure with the 5-0 monocryl. And at 10 days, we can see that incredible healing where it's completely closed over. And we don't see this with really any other barrier membrane that we can leave exposed. And there are others on the market which shall remain nameless. Okay? Again, another close-up of that, we can see that it's almost closed over and it's a very minimal inflammatory response. So, is bone healing then? We know that soft tissue heals well over this when it's exposed, but what about bone healing and regeneration? Is it compromised in any way under an exposed BioXclude? Really good study by Hassan and colleagues that took core biopsies. They compared amnion-chorion membrane versus the DPTFE membranes in alveolar ridge preservation. It was a split mouth RCT, and what they found was that at 3 months, the amount of newly forming bone or osteoid was almost 2.5 times greater under an amnion-chorion membrane than under a DPTFE membrane. Even residual graft particles were significantly less under an amnion-chorion membrane versus a DPTFE membrane. And the one thing that I haven't shown here is they also did visual analog scales to assess patients' comfort or discomfort. And what they found was that with a VAS, there was significantly higher scores of satisfaction with the use of an amnion-chorion membrane versus a DPTFE membrane. Okay, so that makes sense because you don't have a second surgery to have to remove this material. With a DPTFE, sometimes one wing becomes a bit unhinged and it's a bit uncomfortable for the patient because you have to resuture, you have to take it out. Now, in the context of GBR, there was a case series that was done by Homle Wang's group in Michigan, where they looked at an open healing model. They did 3 cases where they elevated their flap, they placed a BioXclude membrane, and they intentionally left this 2 to 3 millimeter area of open membrane. Okay, now this particular case that I took from their paper, they'd used a collagen membrane underneath the bone graft, or on top of the bone graft, covered it up with the BioXclude. But the proof of principle here is that you can leave this membrane exposed. Now what's interesting is that Homle Wang came up with the past principle, so very, very dogmatic principle that we all follow. So it's interesting that he's now showing at least a case series where he's intentionally left the wound exposed. So I respect that, that over time, even his thinking may be changing with that, okay? Okay, so we've answered the questions about soft tissue healing and bone quality. What about, is there a higher degree of infection when you leave this membrane exposed? Okay, so Dr. Ratliff did touch on these studies for those of you that were here, but I'm going to highlight a couple of them. Okay, so this one study by Ashraf and colleagues, they plated AA bacteria on paper, which is their control, on a commercially available collagen membrane, native type 1 collagen membrane, on a tetracycline-coated plate, and a plate that was coated with BioXclude. And what's really interesting is that the kill rate for the bacteria is pretty much identical on the plates that were coated with tetracycline and amnion-chorion membrane, okay, over a 24-hour period. The vast majority of this destruction is done in the first 12 hours, and it kind of plateaus out. So it shows really nicely the antimicrobial activity. The second study compared the growth of S. gordoni, which, as we know, is a bacteria that's involved in the early colonization of biofilms. They found that almost no S. gordoni was viable over a 48-hour period when tried to grow on amnion-chorion membranes compared to, again, a commercially available collagen membrane. Okay? So again, a couple of studies that show very nicely the antimicrobial effect in principle. So for me, just like Darwinian theory of evolution, the germ theory, use of AI, even in implants, platform shifting and whatnot, the use of a material like BioXclude was a huge paradigm shift for me because up until this point that I started using BioXclude, it was all about titanium reinforced membranes, collagen membranes, but this completely kind of changed the way that I look at things. So let's start off with some cases now that we've gotten past the fundamentals. So this is Mark. Mark is a patient that presented to me, healthy guy. At the time he came in 2018, I think he was about 47 years old. He was missing teeth 8, 9, 10, I guess, 8 to 10. You're going to see a mistake in one of my slides. I misnumbered because, again, I'm Canadian, so I look at this as 1, 2, and 2, 1, or 1, 1, and 2, 2. So now, Mark lost these teeth when he was 18 or 19 years old. And he lost them very proudly because when you're Canadian, a big badge of honor is when you lose your teeth getting hit in the mouth with a hockey stick or a puck. So he lost these teeth in a hockey accident, and he'd been wearing removable or an RPD ever since that accident. You know, he's a good-looking guy, handsome guy, wanted to make a change in his life, and was finally thinking about getting dental implants. So his GP, his restorative doc, came up with the idea that why don't we do an implant-supported bridge, 3-unit implant-supported bridge to replace these teeth, and he can get rid of that RPD, hopefully forever. Now, the one thing that I want to point out here is look at how nice and thick the phenotype of tissue is here. And particularly for those in this room that are maybe newer graduates or in their training, I don't want you to make the same mistakes that I made, okay? Which was when I'd see a case like this, I'd get excited. I'd get excited because the tissue was thick, and I thought there was going to be a nice big bundle of bone underneath that tissue, only to go in and be disappointed more times than not. Okay, so there's really no correlation between the thickness of soft tissue and long-standing edentulosum in terms of the amount of bone that's there. Okay, so don't make my mistake and always take a CBCT preoperatively. CBCT is almost now, I'd say, close to, or if not, the standard of care in most jurisdictions, particularly for implant therapy. So we took CBCTs of the area, and we can see that in the number 8 site, there appears to be reasonable thickness of bone, but in the number 10 site, it is rather on the thin side, such that if you were to place implants, do a simulation, you would see that with the number 8 implant, there would be a very, very thin buccal plate. And on the number 10 site, we'd have more or less fenestration or dehiscence. Now, some of you in this room might say, that's okay, I can go ahead, place my implants as long as I get good primary stability, I'll do concurrent GBR, and everything will be okay. And the truth is that things probably will be okay. Like, there's no real negative element to doing things simultaneously. As I've gotten more older, wiser perhaps in my career, I've been practicing perio for 20 years now, I've sort of become more conservative when it comes to treatment in general. Okay, so I'd rather just do one thing at a time. You hear that saying that people attribute to Dennis Tarnow, one miracle at a time. So I'd rather grow the bone, know that it's nice and stable, put the implants in, wait the 4 months or however long you want to wait before they get restored. Okay, I also wanted to use BioXclude for my GBR in this case, so I wanted to make things very, very systematic because the only time I'd used BioXclude before as a sole membrane for GBR was a number of years before this, and I never really documented that case well. So here we go. We're going to start with our incisions. I like to make my vertical incisions 1 tooth remotely on either side. I know some people may do 2 teeth, depending on who you trained with. And I like to make a paracrestal incision slightly offset towards the buccal because as we release this flap, what we don't want is the tissue on the proximals to start bunching up such that we can't get proper closure. We then elevate our flap, and we can see that it correlates very nicely with what we see in the CBCT, in that the number 10 site is definitely more deficient than the number 8 site. What I then do next is I take my bone scraper, and unfortunately these bone scrapers aren't available in Canada anymore, the disposable ones anyway. But if a site is big enough like this, I'll just take bone scrapings from the area from the site itself, because that's going to be my source of osteogenesis. Okay? So, I'll go back and forth with my bone scraper and get as much bone scrapings as I can. Typically, I like in a 50-50 ratio with particulate bone. Now, around this time in 2017, 2018, I guess I was going through a midlife crisis, and I was really influenced a lot by the Europeans who use xenograft because they can't use allograft. And so this case I used with xenograft, and there's nothing wrong with xenograft. I mean, it's very well validated. For some reason in North America, we prefer to use allograft because we're impatient and we want to have faster turnover, et cetera, et cetera. But the vast majority of my cases with GBR are done typically with allograft, okay? So I mix the autogenous scrapings with my xenograft, and then I will graft each of these areas. Now, I've only shown for the number 10 site. I did the exact same thing for the number 8 site, and you can see how nicely that membrane, the BioXclude, just conforms and adheres intimately over that graft. You don't need to suture it, you don't need to tack it, and in fact, if you tried to suture it, or tack it, it would probably disrupt that membrane. So it's better just to use it as the biologic saran wrap that we think it is and just layer it over nicely over that graft. And here's a video that shows how we do this. So we always want to apply this material dry in the patient's mouth. So start off dry, and I place the membrane, allow it to come into contact with the patient's blood, and you can see as soon as it comes into contact with the patient's blood, it starts becoming a little bit more moldable and malleable. And then what I do is, you can see this bowl of sterile saline here. I'll take my cotton pliers, dip it into the saline, and then spot weld around the periphery to really seal it in and lock it up nicely. And then I can just use that same cotton plier with the saline just to tease that membrane into the perfect position that I want it to be in. Okay? So again, no need for trimming. In fact, we advise against trimming the membrane because if you cut it, you're going to lose the biological activity that was there. So you can fold it in over itself, retain all that biological goodness for the regeneration. And this material, as you can see, can be folded over itself. Okay? So you don't need to cut it. You can just manipulate it. There's a bit of a learning curve. Okay? It took me a few cases before I became really comfortable manipulating this material in situ. Okay? And unlike a lot of other barrier membranes, you can actually have this in contact with the roots of the adjacent teeth. Okay? And then this is what it looks like in a still photo after we've gotten it into place. All right? So everything in dentistry is somehow related to food, right? Like we've got the cheeseburger technique and the sausage technique and the hamburger technique and all these things. So I call this affectionately rice paper roll GBR because the BioXclude membrane over a bone graft reminds me of the rice paper rolls that we see at some of our favorite restaurants. Okay, so I use this for horizontal GBR. If I'm using BioXclude on its own, I can only really use it for horizontal GBR. It's not a form-stable membrane, so you can't get vertical augmentation with it. For vertical augmentation, you're going to use it as a secondary membrane over something more form-stable. Any particulate graft you want. I'm not going to be dogmatic about whether to use xeno or allo. Okay? If you have great results with either, go for it. But 50-50 mix with autogenous scrapings if possible. Now, again, I'm not sitting there mixing 50-50 like you eyeball it. If it's maybe 30-70, it's not the end of the world. Okay? As long as you have some autogenous mix in there that can contribute to the osteogenic potential. Now, I put tension-free primary closure with an asterisk because we know from that case series from Homley Wang that maybe primary closure isn't always necessary here. Now, I always go for tension-free primary closure, but there's certain situations where maybe, despite your best efforts, you can't get it. So not to sweat about it. Things will probably heal just fine. And I was trained by oral surgeons in my perio program, and I remember they would say minimum 6 to 9 months before you re-enter a site. Okay, why? Because there's still osteoblastic activity happening at about 8 months. Okay, so I don't understand why people are in such a rush to re-enter after 3 months and 4 months, and then they say that they're disappointed because their bone was too soft. Give it 6 months, and you'll be happier with your re-entries. And I learned this, I appreciated this in particular during COVID when we had a 3-month hiatus from practice, and a number of cases that I was supposed to re-enter at 4 or 5 months got delayed to about 6, 7, 8 months. And I can tell you that I was happy with probably 9 out of 10 of those cases, right? So time is your friend. It's not really going to hurt you. What's going to hurt you is if you try and be too hasty, okay? So back to our case with Mark. So we get bilayer closure, nice and tension-free closure here. At the 4-week post-op, we can see excellent healing. There's like no inflammation. The incision line is barely detectable. At 3 months, we can see continued nice healing and maturation of the tissue. At 6 months, I called the patient back for a pre-stage 1 just to take a CBCT and see how things were healing, prepare him for the surgery. We can see that maybe one of the graft particles has slowly worked its way out, no big deal. And we take the CBCT, and we see really nice horizontal regeneration, especially in the number 10 site. Okay? Now, on social media, you'll see a lot of people that'll do GBRs, and they'll post these amazing CBCTs. Okay? I don't get excited about these CBCTs anymore. All the CBCT here shows me is that there is mineralized something at the regenerative site. It doesn't tell me anything about how that bone is attached to the host site or the quality of the bone. Okay, so until you open things up, you really shouldn't be doing any mental jumping jacks. All this is showing you is that, okay, the stuff you put there is still there, and it looks like it's probably going to be okay. So I called the patient back at 1 month later for the surgery after doing some simulations, and we then planned for a surgical guide. We wanted to do this case guided, right? So the GP that sent him to me worked with their lab, did a digital wax up, and from that digital wax up formed a CBCT guide, which we can then use to place the implants in an optimal position to have a screw-retained bridge from 8 to 10. Okay? So now we have the re-entry at 7 months post-GBR. And when I opened this up, I was blown away with what I saw. Like, this is completely different than what I would have expected. All this bone gain, yes, there's a little bit of that particly appearance superficially, but compared to what we started with and what we ended up with, I was very, very happy with that. Okay, so furthermore, the quality of bone was excellent when we placed these implants through the surgical guide. And we can see here that we have a nice buccal bone shelf that we know now from the literature we should have at least a couple of millimeters, particularly in the anterior, to hedge against the possibility of crestal bone loss, peri-implantitis, and even soft tissue mucogingival deformities. 4 months later, the patient came back for their uncovery surgery, placed healing abutments, and bone levels are pretty stable. And at 6 months following restoration, we can see that he's got a nice restoration, good keratinized tissue, bone levels are more or less stable. There's been some bone remodeling, which is acceptable in the first 6 months to a year. And then at 5.5 years, we can see continued maturation of the tissue, very nice, stable result, stable bone levels as well. I did take a CBCT just to make sure that the bone was still intact, and we can see that the bone is, in fact, very much intact. Okay, so 5.5 years. And I'm really proud of this case because the patient was really happy. He comes in every year very faithfully for his follow-ups. And we published a paper, myself and my colleague, Dr. Howie Tenenbaum. And if you want to read that paper, here's a QR code. Please go ahead and scan that for reading in the airplane on your way back home in a couple of days. This is the first paper that was published that highlighted the use of BioXclude as a sole barrier membrane for horizontal GBR. Okay? So, case number 2, this is William. And William is a 78-year-old guy who's having a failing bridge in the maxillary anterior. You can see that there's endo-treated teeth with decay. So we decided to remove these teeth and place implants in the lateral positions to give him a bridge. Now this case, I'm going to tell you right off the bat, it is not a case that I would highlight as any type of aesthetically superior case, not at all. But I want to highlight a very particular point with this case. So we extracted the teeth, and once we extracted the teeth, I felt around the sockets and noticed that there's pretty much buccal bone dehiscences in every single socket, so we had to do a GBR. My original plan was to do a socket preservation. I didn't have a CBCT because he refused a CBCT, but we took the teeth out atraumatically, then we elevated a big flap to do GBR. Now, what I want you to notice, okay, is I made cortical perforations, and I didn't load this guy with 1 in 50 epi, okay? This is just, 1 in 100,000 epinephrine local. There's virtually no bleeding, okay? 78-year-old guy, no bleeding. And, for surgical photography, this is great because it looks very clean. But from an outcome perspective, this is not what you want to see, okay? So I'm committed now. What do? I've made my cortical perforations. I've scraped my autogenous bone. Again, I use xenograft because, like I said, I was maybe at that point in my time influenced heavily by the Europeans. I did a GBR procedure, rice paper roll technique, got good closure, okay? At 2 weeks, things look pretty decent. At 3 months, things continue to look decent. Re-entry at 9 months, post-GBR, I really want to give this guy time. And the reason that I used the BioXclude in this case was because of its favorable angiogenic properties. This guy already has compromised blood supply, so I don't want to just throw a collagen membrane on there. I want to have something that's going to take an active role in the regeneration. So at re-entry, we can see that we've been able to build up the ridge. It still looks a bit granular, but there's enough here for me to work with to at least place a couple of implants. So I placed a couple of implants, and this is what the ridge looked like before we grafted, so still a big improvement. I placed a couple of implants, and I was so happy to get the implants in that I didn't really pay attention to the fact that the buccal bone was a bit on the thin side, okay? Which now today I would probably augment with hard tissue, perhaps even soft tissue. Radiographs look great. We got closure. This is the uncovery appointment with the healing abutments. We've lost a little bit of bone on the distal, probably because we had thin soft tissue there, okay? Knowing what we know now, needing thick soft tissue, again, I would not let this go. And this is what it looks like at 6 months. Okay, so again, I said not aesthetically favorable result with the retracted photo, but functionally, patient's very, very happy. There's some soft tissue dehiscence here. I offered him the option of doing some soft tissue grafting. He's declined. He's like, I'm fine, I'm happy. There's no pain, there's no discomfort, there's no infection. At 2 years, things look still more or less stable. There's been some recovery of bone on the distal of this implant. At 5 years, we can see that things are still pretty stable, maybe a little bit more dehiscence. Every time I reiterate to him, let's do some soft tissue grafting, he's like, no, it's okay. You know, he's now 83 years old. Maybe some recurrent decay on this tooth. So again, this case really was just to highlight that angiogenic potential of this particular membrane. Now this case is Linda. She had this vertical root fracture on the anterior incisor. So we extracted the tooth, let the area heal for a couple of months. Let the soft tissue close it over. So at 3 months, we decided to re-enter. And we made our incision design, again, for nice GBR procedure. And we see that we have a complete fenestration or dehiscence of bone here, but it's otherwise well contained. So I did grafting with allograft, mineralized cortical cancellous allograft, placed a BioXclude membrane on top. And again, you can see here how it drapes nice and intimately over the graft. It's making contact with the roots. It doesn't matter. Got primary closure. Now it's time for the post-op. So one of the things that I really like about this material is that even at early post-ops, you can see that even though there's been a little bit of exposure here, there's very little inflammation. And do I care that there's been an exposure there? I care from the standpoint that I want to make sure the patient's okay, but I know that this is going to heal just fine. So at 7 days, we can see that there's no real further exposure. Things look pretty good. By 2 weeks, things are starting to close up a bit. And now by 3 months, besides the fact that she irritated this with a popcorn kernel, things are ready to go. Okay, so re-entry at 7 months, we can see that we've got really nice buccal bone regeneration, nice horizontal augmentation. We place the implant, put a healing abutment on, take our radiograph, and now we wait for 4 months. I tried to sneak in a little connective tissue graft here as well to treat the recession on that lower incisor. At 6 months after loading, we can see nice stabilizing tissue and good bone levels around the implant. At 5 years, we can see even further maturation as evidenced by the gingival stippling and a nice stable bone levels as well. Okay, and soft tissue profile is great. And CBCT shows good buccal bone, which is going to help us for the long term. Now, final case here, this is Lloyd. He had this implant placed beautifully by an oral surgeon about 10 years previous. It was restored with cement-retained crown, and over last couple of years before I saw him, he developed this intrabony defect at the mesial distal aspects. So after we put him through non-surgical debridement, we decided that let's see if we can try and save this implant because it was firm. I did tell him that there's a possibility that we may have to extract, but he said if we can save it, let's save it. So on the day of the surgery, we elevated the flap, and we can see that there's been almost complete dehiscence on the buccal, but it's otherwise well contained. This would be a class 1B, grade A peri-implant defect as per Dr. Alberto Monge, means that there's 2 to 3 walls, and the implant is well contained. So we've got good access. Let's see if we can decontaminate the implant surface and get a good result. So I like to use titanium brush. It's a great material, doesn't change the implant microsurface topography, and it doesn't leave shrapnel all over the place. I mean, I've gotten away from aggressively contouring the implant surface. I'll then, you can see that the surface is nice and clean, it's well contained. I then would take a xenograft or an allograft and mix it in with some tetracycline or minocycline microspheres, and then graft all around as best as I can. We then get the BioXclude, place it over the graft, and again, it seals it up very, very nicely. Tension-free primary closure, okay? At 1 year, we can see good soft tissue healing. But at 2 years, and this is something I learned from Dr. Cullum, okay? You got to give this material patience. Look at 2 years, we have creeping of the gum tissue to cover up that exposed abutment, okay? So this is not Photoshop. This is actual creep up of the tissue, and I've never seen this anywhere else. Radiographically, we can see that there's been good consolidation of bone at 1 year and 2 years. And CBCT shows where there wasn't any bone before, there's been excellent fill of bone. Now, whether it's re-osseointegrated or not, I don't know unless this implant fails and I am able to get a block. But so far, I got to go by what I see. And at 2 years, we can see further maturation of the graft and consolidation. And Dr. Tenenbaum and myself, along with our colleague Dr. Goldberg, published this case report in JPRD. Go ahead and scan that for the full PDF link to the paper. Okay. So, some final thoughts and conclusions. I hope I've been able to show you that BioXclude is in fact a very unique material with bioactive properties, and these bioactive properties allow it to decrease inflammation, accelerate healing both in short and long term, and it provides good supports angiogenesis. It can be used for horizontal augmentation as a sole barrier membrane. Okay? Don't let its flimsiness fool you. It's just as good, if not better, than your conventional collagen membranes for horizontal augmentation. In the realm of peri-implant defects, having that antimicrobial property makes it a really, really good option to have on the shelf for treating peri-implant diseased implants. It does not require stabilization or fixation, which for a lazy guy like myself is perfect. We can use this in both a staged and simultaneous approach. I haven't shown you my simultaneous cases. I just want to show you the proof of principle. And again, exposure of the membrane, whether intentionally or unintentionally, does not compromise the soft tissue healing or the quality and quantity of regenerated bone underneath. And with that being said, thank you guys very much. I hope you enjoyed the presentation. If you have any questions, I will stick around as long as you want. And please email me if you have any questions. Follow me on social media. Thank you, Maxius. Thank you, Matt Burns and the team for always supporting me and giving me these opportunities. And have a great rest of the meeting, guys. Thank you. Some more cases on peri-implantitis treatment. So, yes, come around for that.